So our second table starts with two presentations for contrast-enhanced mammography. SEM is an emerging modality that combines digital mammography with the administration of intravenous contrast material for the assessment of neoangiogenesis. Breast cancers can be identified on SEM by density and morphological characteristics on low-energy images, as well as by iodine uptake, intensity, and pattern of absorption on the recombined images. Our first topic is how to use contrast-enhanced mammography in symptomatic surveys, and it will be presented by Dr. Elisabetta Gianotti, who is consultant breast radiologist in the University of Nottingham, UK. Please, Dr. Gianotti.
Hello, good morning, everyone. It's a real pleasure to be here, even if only virtually. I would have preferred to be in Athens than in a grey Nottingham, but I'm really pleased to be here. So I hope you can see my screen. So my talk is about the role of contrast mammography in asymptomatic breast service, and particularly how we use in Nottingham. Okay, so this presentation has been sponsored by GE Healthcare. So in the next 20 minutes, we'll have a look at a little bit of introduction on contrast mammography, how the symptomatic breast service is organized in UK, and particularly how we use contrast mammography in Nottingham. I will present some cases, dividing them in different diagnostic scenarios, and then we end up with a little bit of innovation and look to the future about the role of guided biopsy, chest-guided biopsy. So what are the principles? The principles are the same as MRI. So the contrast mammography work as MRI work. So the iodinate contrast in this case, instead of gadolinium, enhance the area of neoangiogenesis that is typical of tumor that develop these new vessels that are damaged vessels, basically leaking vessel. But the beauty of this technique is that we have a double platform. So we have the digital mammography, the low energy picture that basically is a morphological information, and then we add the recombined image that give us a morphological information. In terms of the physics, is a dual energy acquisition, and I would like to describe, we have a low energy picture where basically the contrast is inside the body, but we can't see it because we can't see the contrast because it's been acquired at a kappa edge that is lower than iodine. Then we have a high energy picture that is not diagnostic, and our machine will show us the recombined picture where beautifully we can see the area of uptake of contrast that are the tumor that indicate the angiogenesis, and again in the CC view. So what about the symptomatic breast service in the United Kingdom? I thought just to give a little introduction because I suspect it's a little bit different than in Athens and in Greece. So basically in UK, if a lady feel a lump, she will go to their GP, and then she will be referred to a one-stop clinic to the symptomatic serving in the hospital within 2 weeks. If it doesn't happen within 2 weeks, the hospital will be fine. So when the patient come to the hospital, we call it one-stop breast clinic, where the lady will have a triple assessment. So clinical imaging, and if necessary, we do biopsy as well. So you can find guidance on screening and symptomatic breast service online if you are interested about that. So just to put things into context, as you know, in the United Kingdom, they use imperial and British measure, like there are a mile instead of kilometer, and even for breast imaging, we use our classification that has been developed from the Royal College of Radiology and the British Society of Breast Radiology, and we mainly use these instead of BIRATs, but just because we basically don't do a lot of follow-up, and we biopsy things more, I think. So, but in terms of the 4 and 5th, category 4 and category 5, they are pretty similar. So if a lady to the BIRAT. So if a lady come to our unit and will be examined by a clinician, if the clinician thinks that is a P4, P5, clinically we'll offer to a lady a contrast mammography as a first-line test. So basically the patient will go to the clinician, will have a clinical examination and anamnesis, and then if the clinician thinks that he's suspicious for malignancy, as radiology, we'll ask the patient if she's happy to have a contrast mammogram instead of a standard mammogram as first line. And this is our checklist that we go through. So basically the thing that we go through, we do between the age of 35 and 69. We ask for allergy to iodinate contra, although very rarely the patient would have CT before. We ask if the patient has renal or liver problem, if she take metformin for diabetic type 2. In presence of pregnancy, lactation of implant, we don't perform a contrast mammogram. So we don't use the EGFR because a UK audit from the British Urology Society showed that it is safe to give iodinate contrast without having the EGFR if the patient is fit and there is no history of renal disease or other risk factor are negligible, while the EGFR is necessary if there is suspect acute kidney injury, no kidney disease, diabetes, or metformin. But of course, would be different maybe in your unit, but just to let you know that we don't check the EGFR because it's a young population. Of course, we use iodinate contrast. We're all familiar with that. We are radiology, we use in CT, but we have to remember even if rare, we can have a reaction even though most of them are mild. But of course, when we use iodinate contrast, we need to have resus and anaphylaxis training. So what is the patient pathway? So we always have when our clinic is on this trolley ready to go. So if it's a patient need contrast mammography, we consent the patient is happy, and then we put the cannula. In the meantime, the radiographer prepare the equipment and load the pump. We then move to the X-ray machine, and is the radiology that give the contrast to the patient. I like to remain in the room with the patient all the time. I think the nice things compared with the CT that when we give the contrast, the patient is sitting next to us and we can reassure them of the strange feeling that they're going to feel. And then we acquire the mammogram. So we use contrast mammography as primary imaging technique. So we use the low energy as a standard mammogram, and the first study that had been published when the contrast mammography was introduced proved that actually the low energy picture are equivalent to a standard mammogram. So the standard mammogram can safely be omitted and safe in dose. So contrast mammography in this pathway has been introduced in Nottingham in 2014, and in 2016 this paper had been published, demonstrated the result of the first 100 cases, showing that contrast mammography is useful and a significant aid in 75% of the cases. So the study has been performed through a retrospective review of the first 100 cases that have been read by 5 radiologists, and basically they've looked at the low energy picture first and then the low energy plus the recombined picture. And it's impressive, as we can see, the rock curve. So this is basically contrast mammography. This is the low energy, and we can see that using the contrast mammography increase sensitivity and specificity of our standard mammogram. And so in terms of sensitivity and specificity, there has been outperform of the low energy picture. The size has been in agreement with MRI and histopathology as well. And as you can see in this graph, basically the darkest area show that for all the reader, contrast mammography is a significant aid to a diagnosis. Most recently have been published other paper in the use of contrast mammography in palpable breast finding, and we can see that the negative predictive value of contrast mammography is high. So this I think is particularly interesting, this point that if the contrast mammography is negative, there is no cancer even if we have ultrasound findings. So it appears to be more specific than ultrasound. And again in this paper can show us that the use of contrast mammography can reduce the number of benign biopsy, so increase what is the positive predictive value of our biopsy. So what about some cases? So I would like to present some cases differentiate in a diagnostic scenario. So the first one are masses. So we can see that for mass, contrast mammography outperforms standard mammogram in terms of sensitivity and specificity. And why I talk about specificity as well? Because when we have like this well-defined mass centrally in the breast, if there is lack of enhancement of this typical rim enhancement as we are used to see it in our MRI scan, it means that it's a cyst. So to give us more information than the standard mammogram. This patient that came symptomatic to our clinic for a mass that was considered P5, so malignant in the right side, and P2, so benign on the left side. And we can see on the recombined picture that there is a ill-defined mass centrally in the right breast, but in the left breast, basically we have a black hole, and this was a cyst. So we can see how we can increase our sensitivity on cyst as well. This was another patient, came symptomatic for a large mass in the upper center right breast, and we can see these rim enhancements were quite irregular, and of course I think we all agree to the fact that these look suspicious, and this is the typical appearance of mucinous cancer. So they give a rim enhancement, but usually the rim enhancement is more irregular than the standard cyst. We have to think about that also benign lesion can enhance, and the degree enhancement is not evaluated in contrast mammogram. So this lady came symptomatic for a mass in the upper aspect of the right breast, but the contrast mammogram saw another little lesion more medially. We look for that on ultrasound. This was a fibroadenoma, this was a cancer NST. And of course, we have to think about the contrast mammography. We'll see more things. It's like can increase the false positive, but the study that have been published show that the false positive are less than in MRI. This was a young lady, 34 years old, came symptomatic for a mass in the retroareal region that was considered indeterminate. So we just did an ultrasound to begin with. The biopsy proved an invasive cancer NST. So as first line in this case as well, if the patient doesn't have a baseline mammogram, we offer to them a contrast mammogram instead of a standard mammogram, especially because in young patients, they are likely to have dense breast. And specifically in this case, we can see our contrast mammogram help the diagnosis and make her confident of the presence of just one lesion behind the nipple. So what about asymmetric density? So the role in asymmetric density in contrast mammography is again about a negative predictive value. So in absence of enhancement, the risk of malignancy is low. So this author evaluated the role of contrast mammography after tomosynthesis in evaluating asymmetric density. And I think the key point is this, that we are more comfortable in dismissing and reducing false positive biopsy if there is a lack of enhancement. So this is an example. Very dense breast, Byrat's D. I think, well, there is an asymmetric density in the upper inner left breast, but in this low energy picture, it's difficult to give them, sorry, a significance. But if we move to the recombined picture, I think we all agree that the lesion just light up in the upper inner aspect, and we all agree that it's very easy to spot up the lesion. This is another example, very dense breast, Byrat's D. I think, again, it's very difficult to give a proper evaluation, especially without previous examination. But if we move to the recombined picture, we're all confident to the fact that this patient has a large lesion in the upper central right breast. What about microcalcification? So Dr. Scapirotta will go in details into that, so just a little look at that. I think with microcalcification, we need to be a little bit more careful in terms of contrast mammography, because if there is enhancement, the calcification are more likely to be malignant, but lack of enhancement does not exclude malignancy, because especially low-grade DCIS, they will not enhance on contrast mammography. But always, again, the beauty of this technique is that we have the low energy picture, so we can evaluate in old-fashioned way the calcification in our low energy picture. So this is an example. I'm very sorry that, it would be difficult to see the calcification, but please believe me, there are these large area of microcalcification centrally in the left breast, and on contrast mammography in the recombined picture, there is a background parenchymal enhancement, but the enhancement shows us the invasive component. It was confirmed on ultrasound. So basically on contrast mammography, we can, in presence of microcalcification, can help us to identify the invasive component. And these we can see that recall the same enhancement of the MRI. This is another case. A patient came symptomatic for a mass in the upper aspect of the left breast. On the low energy picture, there is an extensive area of microcalcification that extended for more than 7 centimeters. But in terms of enhancement, the only area that enhanced was the invasive component. So we have to think about the microcalcification. They might not enhance in the recombined picture, but they need to be taken into account. And in this, I think contrast mammography is a little bit less sensitive in terms of extension than MRI, as we can see in this case, that we can see the no mass enhancement more extensive than on contrast mammography. So what about dense breast? So we know that dense breast, we've already seen this morning, is where we fail more. There is increased risk of breast cancer, and also we perform very badly in terms worst in terms of mammogram. So in this low energy picture, I think I mean, we know that it's dense, but we can't see anything. But if we move to the recombined picture, it's very easy to spot the lesion, the true lesion. So we know that in contrast mammography outperforms standard mammogram in dense breast as well. And also, I think it could be very helpful in increasing our confidence of normality, because if we see the breast like that, I say, well, yes, they're very dense, but the power of a mammogram can be 50–60%, so we can miss things. But if we move to the recombined picture, the absence of a focal enhancement and knowing that the negative predictive value is high can increase our confidence of normality. I like to present this case just because it's food for thought. It's been retrieved from the review of our interval cancer. Patient came symptomatic after 9 months of the screening mammogram. So she did her screening mammogram in February 2017. She came in symptomatic 9 months later, where we can see the lesion that enhance in the lower outer left breast, but it remained occult in the low energy picture. So the question is, if we've used a contrast mammogram, maybe we would have spotted a lesion earlier. And what about the staging information? So this is a quite old picture, but I like to present. I've put in the first slide before, but I don't know if you noticed that there was a further lesion behind the nipple. So we could see all the lesion in the central left breast that is visible in the low energy picture. But if we move to the recombined picture, there is a lesion behind the nipple as well that I think is not visible on the low energy picture. So we know that contrast mammography is very good in terms of tumor size measurements and is as good as MRI. And so help us, as MRI does, in finding additional disease that can be multifocal, multicentric, of contralateral disease. So like in this specific case, we can see the index lesion in the left, central in the left breast, but if we move to the recombined picture, actually we can spot it actually is a multifocal disease that was proved on ultrasound. This is another patient that came symptomatic, 59 years old, with indentation in the left breast. So I give you a few seconds. I think we can all see the lesion central in the left breast. But if we move to the recombined picture, actually the patient had a lesion on the right side as well that I think was not overlooked on the low energy picture. So it helps us in finding contralateral disease as well. And we can see how the image recall and particularly, are the same as our MRI. So using contrast mammography as primary imaging technique can improve cancer detection because increase the sensitivity of the standard mammogram, but also can increase our confidence of normality in women with dense breast. And if the patient has a suspicious finding, as we do in our clinic, can give us more accurate staging information at the woman first attendance, that we can find more lesion and biopsy at that time that maybe otherwise would have been spotted with MRI and then a second look ultrasound. It requests a little bit of more time, but mainly in the time of consent and cannulating. But I think you gain this time in terms of ultrasound, because then you have your MRI, you have your contrast mammography, the recombined picture, and you know what you're looking at or your ultrasound. And I think that may reduce also false positive from whole breast ultrasound. So as we're talking about innovation today, just would like to finish talking about contrast mammography guided biopsy that unfortunately I was hoping to present some cases, but we have the machine available, but our physics due to COVID is not finalized yet. So I haven't experienced myself, but I've seen some presentation from Dr. Alcantara in Barcelona. Until now, there have been 3 machines, one in Canada, one in Paris, and one in Barcelona, but now the machine has CE approval, so will be available soon. So until now, if a lesion was visible only on contrast mammography, the only way to do a biopsy was to do an MRI biopsy, because as we said, they work in the same way, but now it's possible basically to do with a stereotactic guidance to do contrast mammography guided biopsy. And it was pretty impressive when I saw these cases from Dr. Alcantara. He showed his first case. It was a very tiny lesion, and he showed us, like in this presentation, how easy it is to do biopsy. And I think this is a big potential for the future, because we all know how difficult and also not widely available to do MRI guided biopsy with all the things that comport to have an MRI. So you have to have a specific needle. So I do think that in the future this would be a big potential for us. So I thank you very much for your kind attention. Please feel free to reach out for any question. And I put this picture. This was Usobi in beautiful Athens a couple of years ago, hoping that we can meet again soon in person. And thank you very much.
So thank you very much, Dr. Gianotti, for this very, very nice talk. And I have a question from the audience. What is the contribution of SEM in the evaluation of invasive lobular carcinoma of the breast?
Yeah, so unfortunately there are not many data about that, but we've done we've done a little review, and actually we can see that contrast mammography is good, so is at least outperform the standard mammography. So, but I would be very interested to compare to MRI. So, because I think sometimes the problem with contrast mammography is that we see the lesion, but we don't see it as good as such intensely as on MRI. And it's just the principle is basically a physics principle, because in contrast mammography is proportional to the amount of contrast, while in MRI is about how the intensity of in the T1 picture. So I think we can say that is good, is better than standard mammography. But would be interested to look into that in terms of MRI.
Okay, thank you once again. And I would like to move now to the second topic, that is breast calcifications and what is the role of contrast enhanced mammography. It will be presented by Dr. Gianfranco Scaperotto, who is breast radiologist, director of breast imaging unit in the National Cancer Institute in Milan, Italy. Please, Dr. Scaperotto.
Thank you, Professor. Thank you a lot. Good morning, everyone. Thank you, Professor Dimitropoulos, to invite me to speak about our today little experience about the CHEM and microcalcification. Thank you, Professor. And I speak you about my little experience, and I speak to you about the CHEM in microcalcification situation. Now I use, one moment, okay. 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 I repeat, I work in National Cancer Institute of Milan, and I speak to you about our experience. We know that the diffusion of mammography and screening program has considerably increased the detection of breast calcification, but the interpretation remains a great challenge to all breast radiologists. In literature, there are many studies that evaluate if there are some future of calcification that can predict malignancy, and there are some descriptors that can help us to stratify the risk, because mammography has a high sensibility, we know, but the detection is difficult, and the specificity is low. Today is low. We use, I think in Europe is the same, we use the RCR and BRATS 10, can I help you as, because there is typical situation to distinguish benign and suspicious calcification. In particular, suspicious calcification I divide into 3 groups. BRATS 4A with a suspicious inferior to 10%, 4B with a suspicious between 10 and 50%, and BRATS 4C with a suspicious between 50% and 95%. BRATS 5 is greater than 95% in suspicious. For example, some example, BRATS 4B, BRATS A, BRATS 4C, BRATS 4B, BRATS 4B, BRATS 5. But what are the lesions that present with calcification on imaging? Most are benign proliferation. And in general, we don't have a particular problem in presence of benign proliferation. But the problem is for example, B3 lesion, for flat atypia for the FEA, for atypical ductal hyperplasia, atypical lobular hyperplasia, lobular carcinoma in situ. There are malignant lesions, we know, low-grade ductal carcinoma, DCIS grade 1, DCIS grade 2, DCIS grade 3, and pleomorphic lobular carcinoma. There are a lot of malignant lesion, and evaluation of predictive characteristic of malignancy is another problem. The positive predictive value is too low, and we have the problem to over-diagnosis and over-treatment. But it's important to understand what is the DCIS, I think. What is exactly DCIS? What is the biological significance? What is the risk of killer cancer? What is the progression in what time? What are the possible therapy? Is the open question, because the DCIS is a particular disease, more different than normal cancer, killer cancer. There are 1,000 questions, a lot of scientific work in the work, but today a few certain answers. The high-grade DCIS is a different disease than low intermediate grade DCIS, and then different to B3 lesion. In particular, there are two different DCIS. For example, for a high grade, the presence or HER2 amplification and estrogen negative expression. For example, in low intermediate or low grade DCIS, there are typical expression estrogen receptor and lower risk of invasion. It's a very important other aspect of DCIS is very important that are very different level of agreement between high grade and low grade DCIS for the pathologists. There is a high level of agreement for high grade and very, very low to agreement for low grade. So different disease, different problem for the radiologist, for the diagnosis, different problem for the pathologist, different approach for the surgery. And for the surgeon, sorry. So different disease. So, for example, in this other work is very important because untreated high-grade DCIS will evolve into invasion carcinoma in 5 years, measured for 15% of cases. Low-grade DCIS evolving into invasive cancer in 50% of the cases, the same of patient, but in medium in a very, very long time, measured for 50 years, for example. So I repeat, different disease. Other aspect, for me, it is important and particularly work in literature. This is a very interesting study because low-grade DCIS that show that to perform or not perform surgery into low-grade DCIS is almost the same in terms of survival benefit. So DCIS low-grade is particularly, so DCIS high-grade is a very cancer. Okay, this in the world today is an open study that use the surveillance for DCIS. There are some problems, there are some different aspects. In my institute today is open a study that uses surveillance after biopsy for DCIS low grade. So different approach in the world to understand what is the very aspect of different disease. Okay, tomosynthesis or mammography, digital mammography, and stereotactic guided VAB is the reference for the diagnostic today. The underestimation rate is about 20% in the world, and is for the problem to different histological aspects. About 60% of biopsy performed for suspected calcification have a benign histologic. So there are the problem for overdiagnosis and so the overtreatment. Radiologic semiotica today is not sufficient to change this situation. Sorry. We have also another problem. It's possible that this DCIS may extend the extent of visible calcification and remain occult when surgery is planned, because DCIS has a no continuous proliferation inside the lobar duct. This can lead to wider resection, and relapse can occur in the follow-up. Is another problem. Contrast medium may improve disease detection and preoperative suggest the supposed real extent of disease, improving its management. The MRI is today we think that is the queen of the diagnosis of all cancer in the breast situation. So but also the MRI have a problem to DCIS situation. So 10% of false negative result for all DCIS, less sensitive than mammography for diagnosis of poor DCIS. MRI can detect those DCIS that don't present calcification. We need, I think, it's necessary today change the approach. And so I think we need to combine the sensitivity of mammography with the sensitivity of intravenous agent for neoangiogenesis, like CHEN. This is for example, this is a normal aspect that so before extent of disease, disease in the other side. So the use of CHEN improve the sensitivity and specificity of the diagnosis. CHEN is an emerging breast imaging technique that uses contrast enhancer recombine assessment for neoangiogenesis. CHEN has a potential to combine the relatively easy, low cost and variability of mammography with the high sensitivity warranted by contrast medium. But there are some questions. It's important question about CHEN. Can CHEN reduce overdiagnosis or low-grade DCIS and consequent overtreatment? Can CHEN improve predictive positive value of biopsy? Is there a correlation between enhancement and aggressivity? In our study, we try to respond to this answer. And so we decide to try the contrast, the CHEN, in the microcalcification situation. Aim of the study is there are correlation between enhancement and the presence of disease. Is there are a correlation between enhancement and aggressiveness of the disease. Our study, we have published our study in 34 patients with 36 findings of suspected calcification, rates for deserving of BRAS assessment with preliminary subject to CHEN investigation. But today we have 72 cases in study. Inclusion criteria is BRAS4 BC calcification on mammogram, no related mass lesion, and exclusion criteria is problem for renal function, history or allergic reaction to contrast medium injection. Okay, this is CHEN and VAB. We use the diagnosis by CHEN and use VAB to histological diagnosis. This is our result. It's very important to understand that in 36 lesions, we have 11 cases of cancer. And so it's important to this for us And so the lesion with enhancement has dimension greater than 5 millimeter, key 76 over 20%, and were predominantly invasive tumor with R2 subtype of basal-like. Instead, lesion without enhancement has dimension less than 5 millimeter, T76 under 20%, and we have in particular luminal A and luminal B. Is a microfocal extension disease. Summarize, in generally, lesion with enhancement, microcalcification lesion with enhancement is dimension is upper 5 millimeter, T76, then measure 20%, and predominantly invasive tumor, in particular R2 subtype and basal-like. Microcalcification lesion without enhancement is very, very low. The dimension is very low, than inferior 5 millimeter. T76 is inferior 20%, and predominant luminal A DCIS. Some case, for example, in this case, we see that the particularly problem in the breast, extension disease with calcification. Okay, extension disease with calcification. We use the contrast, the CHEN before the biopsy, and so this is the situation. Extension disease, but it's important to see a particularly enhancement in the breast. So in this situation, this is invasive cancer, but it's important to see another cancer in the other breast to bifocal disease. In the MRI, the situation is the same. This is a second look ultrasound after the CHEN, and this is the diagnosis. Right, carcinoma G3 triple negative, T76 55%, and left carcinoma G3 with DCIS R2 positive and T76 is important, T76. Other aspect, this is a particularly situation after quadrantectomy. Is in follow-up, patient is in follow-up, and so it's possible to see the calcification near the scar, and in two different sites. In this BRAS 4B, and so BRAS 4C. We think this calcification is typical malignant calcification, and in fact there are 4C for us. These are some problem to understand because it's near the calcification, and so I think there is the possibility of the liponecrosis calcification in a liponecrosis situation. This situation and so it's possible to see the enhancement in two different sides and so this is a particularly diagnosis. This is with comedocarcinoma is a typical arc shape in this situation. In the MRI is the same. MRI is an arc shape situation. So is a relapse, in total relapse, and the patient make a mastectomy because it's impossible to make a new conservative surgery. Other aspect, BRAS 4C, there are some calcification, but it's difficult to see in this area. This is aspect after CHEN. This I think the DCIS extension, but in this side there is the invasion cancer. This is a diagnosis. Other aspect, calcification, pathological calcification. Pathological calcification. We don't see particularly problem in the other side that after the quadrantectomy is a patient in follow-up. This is BRAS 4C, it's important to see this situation. There are enhancement in the breast near the calcification. This is possible to see the calcification. Other aspect in the chest is an important aspect that is possible to see the calcification after the injection of contrast after injection of the contrast. It's possible to see the calcification. So it's important to understand the topographic aspect of the calcification and the enhancement, but it's important to see the relates in other side, in the other side. This is a diagnosis, carcinoma, invasive carcinoma in one breast, and DCIS with comedonecrosis in the other side. Okay, but it's the same. It's possible to see the invasive aspect of the comedonecrosis, but it's important to see HER2 positive, key 46%. So it's important the high grade of DCIS. Okay, our study, return at our study, our preliminary study suggests that the presence of enhancement as suspected calcification site indicate a disease with a high proliferation index and with dimension greater than 5 mm. Moreover, CHEDM can see calcification, and so it's possible a stratification, the risk with BRAT's approach, based on morphology, and is possible also a greater spatial correlation that help us to biopsy the target. In conclusion, we think that CHEDM could increase the positive predictive value in their characterization calcification, decrease the number of biopsy. It's possible to change, for example, the surveillance and reduce the overdiagnosis. So decrease the overdiagnosis and overtreatment for low-grade clinical indolent disease. So it's necessary, other studies, necessary to improve the number of patients, because our experience is a very, very low experience, but in our sensation is very important, because I think it's possible to change the normal approach for the calcification to help us the use of intravenous injection. So it's necessary to improve the number. It's necessary to study in the world, but I think the use of CHEDM before the VAB or the biopsy in general is very important. Is very important to change the normal approach that we use in our experience. Thank you so much. And okay, thank you. I think a little experience, but I think I opened the possibility to improve the number in the next future.
So thank you very much, Dr. Scaperota, for this very informative presentation. And just in order to make it a little more clear to us, and in the setting of overdiagnosis, if you have some morphologically suspicious calcifications that do not enhance, how do you manage them? Do you avoid biopsy, or do you continue with a biopsy? How would you manage it?
No, use the biopsy. In generally, in our experience, we use, for example, as in BRATs 4B or 4C, we don't have enhancement. Use the biopsy the same. We don't stop the normal approach, the normal strategy that I use in the normal activity, in the clinical normal activity. Use the CHEDM to understand there is or no high-grade situation. I think high-grade situation for DCIS, but we don't change the approach that after the BRAS classification and stratification. And today, this is the situation.
Okay, thank you once again. And I would like now to hand over to my co-president, Dr. Andrea.
Good morning, dear colleagues. Our topic today in diagnosis is how DBTR screening tool can make things clearer. We know as far that DBT has increased rates in invasive cancer detection.
Yes.
We know that improves the specificity and the sensitivity, especially with CAD. And we know that DBT decrease false positive recall rates and that decrease radiation dose with synthetic views. Also, that increases the accuracy in BI-RADS assessment, but we have overdiagnosis in radial scars and distortions. DBT increases the relations between cost and effectiveness. We have to have an additional IT storage and connectivity, and we have higher reading time. All these things we ask from Mr. Sehopoulos, who is Associate Professor in the Department of Medical Imaging and at Radboud University Medical Center and Dutch Expert Center for Screening, to clarify. Mr. Sehopoulos.
Thank you very much. Good morning, everybody. Thank you for the invitation. Yes, I'm here to talk about how we could reduce reading time in tomosynthesis. Let me try to share my screen. I hope now you can see my slide, because I can't see you anymore, so you let me know if that's not the case. My talk today is about approaches to reduce reading time to make to see if we can make DBT possible for screening. These are my disclosures, it was exciting actually to listen in the previous panel that this topic already came up, that DBT is slower to read because of the amount of number of images that need to be read. So, I'm trying to here answer the question as, can we read DBT fast enough to make it feasible for screening? And I believe that yes, we can. And I want to spend the next 50 minutes or so showing you the possibilities to get us there. And the thinking for this is, well, we need to think about how many images we need to read. First of all, if we are talking about screening mammography, that is an easy question about how many images we need to read per case. We of course acquire 2 views of each breast. So for a normal screening woman, we have to read 4 images. However, in a screening tomosynthesis exam, the answer to this question is not that obvious, or at least is not 100% defined yet. The most conservative or traditional way to think about tomo screen would be to do both full-blown tomosynthesis and mammography, so 2 views of each. But of course, tomosynthesis, each view involves a whole stack of images. And if we think that the average breast thickness is about 50 millimeters, we get 50 slices for each acquisition. 4 views times 50 slices, that's 200 images. And the 4 views of mammography, that gives us 204 images that we would have to review in a tomosynthesis screening exam, which is of course is much higher than the 4 images we have to view in a mammography screening exam. So being inspired a little bit that we're all supposed to be in Greece, and of course Greece has a great basketball passion and team. I would like to use basketball as the idea of this competition between tomosynthesis and mammography, and that we're trying to, as opposed to basketball, go in reverse. And we have 204 images to be read for tomosynthesis versus 4 for mammography. And I have 15 minutes to get this 204 number to be as low as possible and to be as close as possible to 4 images in mammography, so that we can actually read a tomo screening exam on average as fast as a mammogram exam. So how am I going to approach this? Well, let's see, there's various options. One of them, that there's been at least a few trials looking at, well, we can read a tomo exam that's only MLO view acquisition only, and not, we don't need the CC view, and of course, probably with a synthetic. So in Malmo in Sweden, there was this large prospective screening trial with 15,000 women, in which they did acquire and read only the MLO view tomo image, and they still had a considerable increase in the cancer detection rate by about 34%. And the recall rate did go up, but it was the baseline mammography recall rate was only 2.5%, one of the lowest in Europe. So it is normal that it also went up by 44% once you are finding more cancers. We also did a retrospective study in which we had radiologists from two sites, actually from our side here in the Netherlands and also from the Malmo team, read the same 181 cases with one view tomo, then one view tomo plus one view mammo, then the full-blown 2 views of each, and then separately the 2 views of mammography. And what we found is, again, that one view tomo gives you enough performance, and the addition of additional views, either mammography or tomosynthesis, didn't improve performance any further. So one proposal is, well, we could read only MLO tomosynthesis and screening, and that would be enough, and it would actually improve upon mammography screening only. So now I spent 2 minutes, and I already reduced the number of images that need to be read on average by half. So now the score is 102 versus 4. Now I'm a physicist, I'm not a breast radiologist, so sometimes I do use physics to solve problems. And one of them I want to talk about is that thickness and separation is not the same thing. What I mean here is that if you take a breast phantom like this one, this is a 3D printed breast phantom in my laboratory that inside has a breast structure that is based on a patient's breast CT scan. So on the left, you see the central slice, which is a very thin slice of the breast phantom as it was sent to the 3D printer to be printed. The white pattern is, of course, the represents the glandular tissue, and the darker gray is the adipose tissue. And on the right, you see the central slice of a tomo image of that phantom. And you can see that there's a lot of tissues here represented in this slice of the tomo slice that you don't see in the central slice of the phantom. So what I did was I combined the slices of the 3D printed truth of the phantom, and I kept combining many, many slices until I could see everywhere in the true image on the left, all the plastic that was present that eventually I could see in the central tomo slice. And the amount of plastic that had to be present in this central slice for it to be representative of everything that I could see on the tomo slice was about 5.5 millimeters worth of stuff. So what this shows is that this tomosynthesis slice is actually showing me not 1 millimeter thick of tissue, but 5.5 millimeters of the central portion of the breast. So in essence, the question is, if tomosynthesis, as we know, the vertical resolution is that poor that one slice is 5.5 millimeters thick, at least with that system, then why are we slicing the breast into these 1 millimeter separated slices? So slabs show us the true amount of information we actually get from tomosynthesis. So people have been looking at, should we read only slabs when we look at tomosynthesis images? And the earliest study probably was this one from the Malmo team, in which they looked at the image quality, only the image quality of this 2 millimeter thick slabs, and they were able to look at these slabs 20% faster with equivalent image quality that was apparent to the readers. Then they wanted to see how much thicker they could go, and two expert radiologists looked at how many lesions they could detect when the slices were thickened from 2 millimeters to 6 to 10. And at 2 millimeters, they could see all the lesions. At 6 millimeters, they started missing a few, and 10 was definitely not reasonable. but it also depends how you combine all these slices into slabs. We did the study a few years ago in which we combined the 1 millimeter slices into 8 millimeter slabs with an overlap of 3 millimeters, with this somewhere between averaging and MIPing the slices together, so that we would get both the best depiction of masses and calcifications. And we did this, again, this ROC study with 167 cases with images from a hologic system and 4 experienced breast radiologists. And we ended up with a performance that was actually equivalent between the 1 millimeter slices and the 8 millimeter slabs, but with a benefit that the reading time went down by a significant portion, 30%, when the readers only had to look at the slabs. So another option is then, therefore, to do only MLO reading of DBT slabs and not slices. So if the slabs have we have slabs every 3 millimeters, the number of images goes down by a factor of 3. So now we're already at a comparison on an average case of 34 images to be read instead of 204. So we're getting closer. Of course, what we don't know is if we use different systems, different tomosynthesis systems that have different angular range and therefore a different vertical resolution, is this also just as valid? So as we know, for a wide angle tomosynthesis system, the vertical resolution is considerably better than for other systems. The amount of information in the same slice increases the narrower the tomosynthesis angle. And something that can give us a little bit of an idea that this might be dependent on the range, the angular range of the tomosynthesis image, is this results from the Retomo trial in Italy, in which they also looking only at slabs plus the synthetic 2D. And yes, there was a 20 to 30% reduction in reading time, but the sensitivity did suffer. So that was one study that showed that perhaps this might not be a working idea, at least in narrow angle tomosynthesis. Another question that we have is, with tomosynthesis, is that European double reading really necessary, or can we do more of the American approach in which we have single reading? So there has been studies about this using the STORM and the STORM trial, 7,300 cases, a prospective reading trial, and the single reading of mammography plus tomo showed still an increase of 40% in the cancer detection rate, with a nice reduction in the recall rate. In Cordoba, in Spain, single reading of tomo plus the synthetic mammography this time still gave a 20% increase in cancer detection rate, with now 42% in recall rate. So it definitely seems like single reading of MLO only DBT slabs could be also an option. So that's another way of reducing the number of reads per case on average. So now we're already at 17 images per tomo case. But let's say perhaps the radiologists are not that confident, and we've been doing double reading, well, for many, many years. So let's say that that's perhaps not a great idea. So one other option would be to incorporate AI into the tomo reading. As we know, over the last 5 years or so, the tomosynthesis, that's not my screen, I think. Sorry about that. Let me try to get back to my screen. Okay, I think you're back to seeing my screen. I don't know what happened. Okay, so as I was saying, over the last 5 years, deep learning has been introduced into AI interpretation or CAD interpretation of images, and the performance of AI interpretation of mammography and tomosynthesis has been shown to be very, very good. So it's been exciting times. And one application of this we proposed is to use AI for hybrid reading of hybrid double reading of tomosynthesis images and screening. So, for example, right now, of course, there's a standard double reading setup. You have 2 human readers, and when they disagree, you have a third reader called an arbitrator to decide who was right and if the woman should be recalled or not. What we propose is to have, yes, 2 reads, but one of them is the AI system reading. And if they disagree, if the human disagrees with the AI, then a second human, a third reader, would decide who is right. So of course, this involves a substantial reduction in the workload of the humans, not exactly 50% because the arbitrator does do more work, but you still get a 44% reduction in the number of human reads. Greatly, the sensitivity remained the same in this retrospective simulated study, but the specificity actually went up. So the false positive rate actually went down. And that was seems a very promising strategy. So we could do either single reading or hybrid with AI reading of MLO DBT slabs, and that would reduce the number of reads. Another option to reduce the number of reads by half. So we're still again at 17 slices or images per case on average. But since we're talking about AI, another application for AI is, of course, AI-assisted navigation and reading of images, and especially in tomosynthesis. This could be very helpful, and that there are already products that of the whole AI tomo stack, the AI already marks with a perhaps lighter gray mark where there is a lesion, and if you click on that, then it takes you to the right slice of where the center of that lesion that was detected, and then you don't have to do the whole search across all the slices, or at least you're assisted in navigating through the slices. And last year, I guess it's been 2 years already, commercial product with 260 cases and 24 breast screening radiologists, and they found that indeed with this AI-assisted reading, the reading time goes down by half, and the performance goes up substantially, at least 6 percentage points in the AUC curve. So that's a very nice strategy. And interestingly, each of these circles is the performance in the 24 readers. This is without AI. The blue line is the AI standalone performance. You can see it goes right through the performance of the readers. But of course, the readers, as we all know, they all behave in a very varied way. The interesting thing is when they use AI for assistance, not only do they get better, but also they all seem to work more homogeneously, if you will. So it does help everybody go up and to the left in the ROC curve, which is nice to see. So that would reduce the reading time, let's say the average reading time, by half again. So now we're almost there. We're at 8.5 images on average per case. And maybe, again, if we push AI to its limits, then perhaps we can use it for pre-selection for no human reading of the very normal cases. So the idea for this is if a AI system classifies all the cases from 1 to 10, with 10 being the most suspicious for presence of cancer. Of course, hopefully the cancers are all getting a 10 or a very high number, and there are very few cases, cancer cases with very low AI numbers, and the normals will usually be spread out evenly across all the scores. And if we draw a line, let's say down the middle, and we say everything to the left of this line, we don't read at all, then it would be possible to decrease about 50%, of course, the number of cases to be read. In this retrospective study, we saw we would have incorrectly pre-labeled 7% of cancer cases as normal, so those would have been missed, but also the false positive rate would have gone down by 27%. If you want to be more conservative, you can draw that line at a score of 2. You don't get, of course, as much of a reduction in cancers to be read, but you don't miss, in essence, any cancers, and you do still increase your specificity a bit. We're not the only ones who've tried this. The group in Malmo, again, also tried the same strategy. And they also actually went back and looked at the 8 cancers that the AI pre-selected as normal, and the 8 cancers were clearly visible. So that's good news. I mean, it's bad news for today, but it's good news for the near future, because hopefully if the cancers were clearly visible, the AI could be improved in the short term, and we wouldn't have those easy errors that the AI makes. So if we incorporate that, then we would have only half human single or hybrid reading of MLO DBT slabs, and that would help us achieve the same number of images to be read per case on average between mammography and tomosynthesis. And I ran out of those 15 minutes. I had to propose all these options. So in summary, how do we implement tomosynthesis-based population screening? Well, perhaps we should need to look at only one view per breast, do only a single reading of each case, maybe reduce the slices to slabs and end up with only 5 to 10 slabs per view. And about half the cases should be human read, and the other half should be read by AI, and or AI should help the radiologist read and navigate fast across the cases. I should say, of course, a lot of these studies have used enriched data sets, not all of them, and a lot of them have been involving retrospective reads, so there's a laboratory effect. It's not in the real screening scenario, so there's still a lot of studies to be made, especially prospective trials. And of course, the one thing that we don't know is, these are all individual studies that show that every loss is small and non-significant if there is one. But if we try to combine all these options, at what point are we losing many times small little things, and then eventually it becomes significant and therefore unacceptable? And that's another question that we still need to answer. So that's it. Thank you very much for the invitation, and looking forward to visiting Athens soon.
Thank you very much, Mr. Sachopoulos, for your super interesting presentation. I would like to ask you one question. Which model, in your opinion, will dominate in the near future?
In the near future,
DBT screening.
In the near future, I think the idea of this hybrid double reading, so having an AI do one of the reads, would be most acceptable. I mean, I would ask you, the radiologist, and then it would be interesting for the women, because that is the one in which all cases are read by at least one human radiologist. So there's a less of an ethical question. And we, of course, again, this is a retrospective study, but it seems like the workload, but it actually improves specificity while we detect all those same cancers. So I think that's a very low threshold barrier. The other ones that are based on, we should do only MLO reading, MLO acquisition and MLO reading, and single reading, I think there's more evidence for that. So those are also, and those don't open any ethical question about AI reading. So those I also believe that we have plenty of evidence for those.
Thank you very much. We will proceed now with a lecture of Dr. Dori Foru. She's a lead of a U.S. department at Air Force Hospital, Athens. She will explain to us all the advanced ultrasound technologies in breast and axilla. Go on, Hortensia.
Hello. At first, deep apologies to Professor Sachopoulos for sabotaging his excellent presentation. Apologies. And apologies to the audience for my technical difficulties. This is Hortensia Doriforu, and the next 20 minutes I will engage you with the advanced ultrasound technologies in breast and axilla. I declare no conflict of interest. So over the last 2 decades, there has been a revolution in the area of ultrasound technology in medicine, and new software had improved the visualization of lesions like BFlow, ultrafast Doppler, 3D imaging, which of course allows better visualization of a lesion in different planes and allows better characteristics to the lesion and to the surrounding tissue. ABVS, which of course is operator independent, and again, it allows 3D imaging. Fusion with MRI can be used in dedicated cases for second look ultrasound and potential biopsy. Artificial anatomic intelligence, again, can be implemented in ultrasound, improving the daily routine workflow, initiating smart features such as auto-annotate, find orthogonal, etc. And last, elastography, strain and shear wave, which are based on physics, are very innovative techniques and have shown high sensitivity and specificity for characterizing lesions. And even more recently, the use of contrast-enhanced ultrasound in breast assessment, not only breast assessment, but also in detection of sentinel node. So please allow me to focus on the last two because of my previous experience in the UK. So both methods, just to let you know, are very operator dependent and therefore experienced operator is needed. We need to follow the guidelines published by the World Federation of Ultrasound in Medicine and Biology, and we need to incorporate elastography in our practice, given the cutoff values for characterizing benign from malignant lesions. So what is the value of elastography? Elastography helps in differentiate benign from malignant lesions. Provided the cutoff value of 80 kilopascal, which is very useful. By this, we can upgrade or downgrade lesions and avoid benign biopsies. It gives a qualitative and quantitative method with high intra and inter-observer reproducibility. Can assess the stiffness on a lesion inside the lesion or in the periphery, the so-called shell, which is measuring 1 to 3 millimeters. There is a correlation with malignant subtypes, and there is correlation with grade and histological biomarkers. Of course, there is a role in monitoring treatment response. So what is the correlation with subtypes, grade, and other important factors? Just to remind you, estrogen and progesterone receptors are useful markers in hormone therapy, and HER2 growth factor is valuable predictor of response to trastuzumab, which is the monoclonal antibody against HER2 receptors. Ki67 is another factor associated with cell proliferation, known as a poor prognostic factor. So IDC, invasive ductal cancers, are stiffer than DCIS, grade 1 are softer than grade 2 and 3, triple negative, HER2 positive are stiffer than ER positive, which is the luminal A type. Ki67 tumors with high Ki67 factor show great stiffness and heterogeneity. Mucinous, DCIS, lymphomas, and small invasive ductals, regardless the grade, may appear soft in shear wave. And of course, there's a correlation with tumor hypoxia. So with regards to the tumor hypoxia, just to remind you of the chain, hypoxic tumor microenvironment is associated with poor prognosis. Hypoxia in breast can stimulate angiogenesis and fibrogenesis, which increases tumor stiffness, and tumor stiffness promotes tumor progression and metastasis by changes in the vascular epithelium. So if there is a way that we can assess hypoxic tumors with shear weight, then we have a good prognostic factor. And yes, we can correlate it with hypoxic tumors. Let's see some clinical cases. A symptomatic lady presents with an ultrasound taller than wider lesion, well-defined borders. On shear weight, we get soft values, very reassuring, and it was a fibroadenoma. Another case, symptomatic young lady with superficially located solid lesion with some posterior enhancement, good performance by the other consultant on another manufacturer's elastography. It was reported as Byret's 4A, and she came for me, and my elastography with my manufacturer machine showed soft values. Again, because of the discrepancy, I had to biopsy, and it was just a juvenile fibroadenoma. Another case, annual mammogram, a colleague noticed a small nodule on the MLO projection, very reassuring on the CC, nothing to see on CC. On ultrasound, corresponding to this area, there was a rather solid nodule, and adjacent, there was a cyst. I've done elastography in both cases, both lesions, with soft values. Of course, I did aspirate this, and it was just a cyst, and I did a biopsy in the other one, and it was just benign changes. Another challenging case, large papillary mass on presentation in a relatively young lady. B mode is very misleading because of the well-defined borders, posterior acoustic enhancement, some hyperechoic echo inside the lesion, could safely attributed to a complicated cyst, otherwise a Byret's 3, but with shear weight, we see the stiff surrounding rim, which immediately upgrades the lesion from Byret's 3 to Byret's 5. So change the scenario. I did the biopsy, and it was a medullary cancer. Another case, a young female, palpable diffuse thickening, so she had a mammogram, and it was in the upper outer quadrant, diffuse pleomorphic macrocalcifications, very suspicious. On ultrasound, one could agree that there's nothing much to see, only to guess the area. Nothing really exciting on the Doppler, but with the shear wave, we see very high stiffness values indicating a high-grade malignancy. And it was a high-grade, grade 3 invasive cancer with high-grade DCIS. The next case, very fatty breasts with a spiculated lesion, easy cheesy. On B mode, definitely Byret's 5 lesion. But what happens with the shear weight? The values are relatively soft, which means we would expect a low-grade cancer. And it was a grade 1. And it, ultrasound guided wire excisional biopsy followed. Double assessment for this older lady. You see there are 2 lesions, one behind the nipple and one in the medial part of the breast. So with regards to the lesion behind the nipple, this lesion could be a Byret's 2/3, could correspond to a complex cyst. But what happens with the shear weight? Perilesional stiffness, very suspicious. How about the other lesion? It corresponds to an asymmetric angular lesion with a thick halo. And And on shear wave, it's confirmed with very high grade values. So we expect a high grade malignancy, and it was a grade 3, and the other lesion was a papillomatous lesion with atypia. Another case from the UK, first round, 53-year-old lady, barely seen asymmetry on the medial part of the right breast, and on ultrasound, very easy to report malignancy. What is the role of shear wave? Very enhancing our decision to biopsy. And it was an invasive ductal cancer. Another case, unremarkable mammogram, maybe hazy glandular area in the center of the breast, but on ultrasound, we see an asymmetric hypoechoic area, maybe taller than wider, very suspicious. But on shear wave elastography, we get soft values. Again, because of the discrepancy, we need to biopsy. And it was PASH, pseudoangiomatous stromal hyperplasia, which means a benign situation. One of the great mimics in mammography is microcalcifications, and we are aware most of the times we have to perform a stereotactic core biopsy to confirm the diagnosis. Is there a place for shear wave elastography? Yes, there is, since shear wave elastography can evaluate the stromal stiffness and help us in the ultrasound guided biopsy, which is easier and much more well tolerated by the patient. So in this Chamming's paper, we see this pleomorphic calcium. There is stromal stiffness, and it's a DCIS, comparing to these chunky calcifications, which the shear wave values are of a soft lesion, and it's just benign changes. This slide I borrowed from Dr. Kesha's talk in Sonoworld, and schematically explains the role of auxiliary staging and treatment. Just to remind you that a positive node biopsy result allows patients triage to auxiliary surgical clearance in one stage with lumpectomy. In case of a negative node biopsy, a sentinel node dissection is offered in the theater with a lumpectomy. If the sentinel node is positive, then the patient will be offered another surgery on a second stage with all the consequences. So the role of imagers is very important to identify the sentinel node and perform the percutaneous biopsy, core biopsy, before the time of surgery, and help the surgeons do the correct surgical planning. Is there a role for shear wave elastography in identifying malignant infiltrated lymph nodes? There is a proposed color pattern for differentiating, starting from homogeneous blue to heterogeneous with high stiffness nidus inside the lymph node. And this is side by side the tables of color-coded classification, which correlates with shear wave pattern with malignant infiltration. And let's see a case. This is symptomatic.
I'm very sorry. Could you please speed up a little bit, because we don't have enough time. Thank you very much. I'm very sorry for the interruption.
Okay, so the the tip of this slide is that I did elastography on the lymph node, and there was a stiff value, and it was an infiltrated lymph node. Let's move now to the next part of my talk, which is the value of contrast-enhanced ultrasound. It's a non-invasive technique using a specific contrast agent, which allows the visualization of microvasculature in breast lesions, detect the sentinel node, improves the sensitivity when assessing lymph nodes, determine if a suspicious lymph node is a sentinel node, and biopsy for further evaluation, and assess the post-treatment results. Again, some models of enhancement. I wouldn't stay in this. Let's follow the arterial enhancement in this 55-year-old lady with invasive ductal. And there is a regional arterial enhancement compatible with the malignant subtype. These slides were borrowed from another USOBI meeting, and we see that there is avid enhancement, and we can not only evaluate the arterial enhancement, but we can also evaluate the time intensity curves and malignant lesions, so faster uptake and demonstrate a steep time intensity slope. This is an example of how you utilize Zeus in the response of neoadjuvant chemotherapy. This is the image 4 weeks after neoadjuvant therapy. No much change on the B mode. And with the Zeus, we see that the time intensity, the peak intensity time, is shorter than the initial one, which means there is some malignant potential. No change in size, faster uptake, steeper curve, and there is an indication of poor response to neoadjuvant chemotherapy. Another good example of gray zone, because hyperenhancement is not always malignancy, and this is hemangioma. Now, if we move for the sentinel node detection, we need just to see this slide for the distribution of the lymphatics in the breast. A clinical case would try to find the sentinel node, and we need to follow the lymphatic vessel penetrating the fascia. And we see this lovely lymph node, which is the sentinel node. Another video. Again, we need to identify and biopsy the sentinel node. And we'll see the avid uptake of contrast enhanced by the sentinel node. And the biopsy showed it was a negative lymph node. Another case, no prominent nodes on B mode. Again, I was able to identify the sentinel node. This is the sentinel node, and the biopsy was negative. Another case, again, we need to identify the sentinel node. This is a trimmed video. It takes a few minutes to identify the sentinel node. And it was negative on pathology. Another clinical case, I'll go through it. It was a pathology positive, but we needed to identify if this node was the sentinel one. So this is the Sentinel node. There is future role of contrast enhanced in targeted molecular imaging, targeted therapies, and gene therapies. And I will give you this slide to test yourself. Almost unremarkable mammogram, but there is an asymmetry in the lower part. Prominent axillary lymph node will give a tip. On B mode, there is a huge 5 centimeter asymmetric area. High stiffness values, not so high. I would expect a low grade of carcinoma. The lymph node is also assessed by shear wave. And it was infiltrated lymph node in grade 1 invasive cancer. So at last, the combination of modalities and ultrasound adjunct tools can lead to images to safe diagnosis. Thank you very much for your patience and attention, and stay safe. Thank you very much.
Thank you, Mrs. Doriforu.
We would like to continue with our clinical comments with Dr. Psekapadakis and Dr. Nasikas and Dr. Hatzilia. Please, let us start with our clinical comments for the time being.
Καλημέρα, good morning, everybody. Γεια σου, Μαριάνθη.
Καλημέρα και από μένα.
Καλημέρα.
Kalmera, everybody. Good morning.
I'd like to say that the only hope for women with breast cancer is the early detection. So I thank you for your excellent presentations. Novel advances in breast radiology, such as contrast enhancement, mammography, seem to be very promising. And as such, they are always welcome towards the benefit of our patients. It was a very excellent meeting, and I hope in the future of the technology. My colleague, Mr. Nasikas, has some comments about these presentations, and we'll hear him now. Okay, thank you.
Hello, good morning. I would like to thank each and every one of the previous presentators. Those presentations were enlightening in a very specific field of breast radiology. I think contrast enhanced mammography puts the breast radiologist in a central role in breast diseases and breast lesion. I'm always more than happy to see advances in breast radiology. So my comments, please be perceived under the scope of a shared responsibility towards the benefit of our patients. And I would like to stay in the contrast enhanced mammography technique, which seems to be very promising. Although it bears some limitations, I believe it's here to stay. Maybe in the near future, we will be having a widespread use of the contrast enhanced mammography, although there are some issues remaining. And I will point out some issues right now, and hopefully we'll trigger the discussion over contrast enhanced mammography. So number one, we've seen an excellent presentation regarding the microcalcifications. What is the negative predictive value? We need to know some data from rather larger studies so that we can validate the negative predictive value and, of course, avoid unnecessary biopsies. That's a critical issue in the mammograph, and was presented with a very fine way from the previous speaker. Another issue that I've pointed out is like, we know that breast MRI bears a rather high false positive rate. So can we diminish that with contrast enhanced mammography? Are we there yet? Of course, more studies will be needed towards that direction. And number 3, regarding the low-grade DCIS and the discrimination using contrast-enhanced mammography, and what happens in infiltrative ductal lobular carcinoma, and in terms of boundary speaking, whether this has altered the surgical planning, the preoperative surgical planning. That would be a question I would like to pose, and hopefully will trigger the discussion. Thank you.
Are we continuing with Mrs. Doriforu?
Go on, Tula.
Hello, everybody. This is Cyprus calling. First of all, happy birthday, Mammography. And I would like to thank everybody for delivering these great presentations, and of course thank our chairman, Mr. Dimitropoulos, for giving me the opportunity to comment on them. I would like to say for a start that the ultimate goal for everybody involved, breast surgeon and radiologist, is the patient. And in that perspective, any tool or weapon that provides us with the opportunity or the means for a better outcome for the patient is both needed and welcome. And therefore, it's very interesting to witness the advances of contrast-enhanced mammography. Studies have shown that it performs similarly to MRI in cancer detection and tumor size estimation, and of course, monitoring treatment response. We know the gold standard is the MRI, but it has the potential of delaying the diagnostic process. In contrast-enhanced mammography, the information can possibly be obtained in the first patient visit. This is such a promising idea. When MRI is not available or is contraindicated, contrast-enhanced mammography is a very useful alternative. The most significant challenge of enhanced mammography relates to the administration of contrast material, but for most radiologists, which work in a multi-service radiology center like me or a hospital, this is a familiar territory. I think we can overcome this. And it is very interesting and promising that some vendors are now offering contrast-enhanced mammography biopsy. Since MRI-guided biopsy remains relatively difficult, and it's also very expensive. I don't know, can I comment on Mrs. Doriforu's speech, or can we talk about it later? I don't know. I think we all know that the presence of axillary lymph node metastasis and the number and location of positive lymph nodes determines the pathologic stage of breast cancer and is the most important predictor of overall recurrence and survival. But the mere identification of nodal metastasis is in the axilla by using imaging is now insufficient. The wider use of sentinel node biopsy or even no axillary surgery in early breast cancer will increase the need for more accurate imaging methods of diagnosis and prediction of axillary nodal disease. And then, therefore, we must provide accurate imaging, as failing to recognize a residual chemotherapy disease, for example, will have significant potential consequences and may lead to misrepresentation of prognosis, especially in more aggressive tumors. And finally, I think that the cornerstone of oral efforts is ultimately the early diagnosis of breast cancer. we know that screening mammography has reduced breast cancer mortality, but nearly half of the interval cancers and large screening detected cancers are visible in retrospect. And the screening mammography has limited value in women with dense breast. We know that DBT depicts more cancers than full-field mammography. Yet in Europe, we have not widely implemented DBT in screening programs. Why? Because DBT is raising the cost of equipment, but it significantly increases the reading time in an era where the shortage of radiologists is an issue or is going to be an issue in most countries in the near future. The pandemic has led to major throwbacks or cancellations of national screening programs. And of course, we realize that even if we implement DBT, we are still going to miss some cancers. The implementation of artificial intelligence screening has the potential to address the workload issues and maximize cancer detection. It has shown potential to reduce interval cancers, and that means it visualizes some of the cancers that are missed in screening by radiologists. I think an attractive possibility is the triage of negative mammograms, that is, preselection of normal mammograms, that would potentially reduce the workload of radiologists, reduce reading time. Sometimes I have seen that artificial intelligence is proposed to obviate the need of a second radiologist. These are very inviting scenarios which we need to observe and study, but also raise some medical legal issues. For example, if a cancer is missed by AI, which will be to blame, AI or the radiologist? If the reader is only AI. Also, what are the profiles, the biological profiles of the cancers that we miss as radiologists and AI detects? If we're going to detect more low-grade DCIS, I don't think that would be significantly important, significantly have a significant impact on screening. Artificial intelligence also is proposed for diagnosis decision support. As a radiologist, though the performance of artificial intelligence is very impressive, I cannot arbitrate for the use of artificial intelligence alone. There are issues like the ability of or the inability of AI to compare prior and contralateral examinations. As human radiologists, we rely heavily on this comparison to decide whether we need to do something about a lesion. Risk stratification involves information about personal and family history of the patient. These are not included in the studies that we compare artificial intelligence and humans. In all the studies that I have seen, these factors are excluded from comparison.
Okay.
I'm not against artificial intelligence. I'm a very earnest radiologist which expects artificial intelligence to assist me. And I see artificial intelligence software in generating smart synthetic images, localizing and finding detected in multiple images, enhancing microcalcifications, or ultimately in confirming the absence of lesions. But also, it is very attractive to see the artificial intelligence in a real screening environment select a patient to remain for extra imaging, for further studies. and say and not come for a report. But we need large prospective trials to do that, and study artificial intelligence performance in a real screening program. And of course, we need to educate radiologists, and especially the younger radiologists, to work with AA, as it is the future. We are not familiar with working with artificial intelligence, and we need to be. Whether it will wholly replace radiology, human radiology, I don't know. I doubt that, and I certainly hope that it doesn't replace humans. But on the other hand, our ultimate goal is not a race between human radiology and AI, but the patient. What is the best for the patient? Thank you.
Thank you, Mrs. Hadilira. I would like to thank all the clinicians for their comments.